Unified conferencing. Hey Janelle, this is Rich. Are you on yet?
Good afternoon, Janelle.
There you go.
Oh, hi.
Think they can see us, right?
I hope they can't see me. You can't see me, can you? All I see is a Polycom presentation. Okay.
Okay. Janelle went into the corner so that she could eat, and now I've called her out about it. I'm just messing with you.
Is it okay if I eat them?
Yeah, totally. So for folks who are on the call, we're going to get started in about 10 minutes.
Hey, Janelle, are you all set for your meeting?
Oh, Jesus.
Hey there. Yes, we are all set. Thank you.
All right. Bye-bye.
Let's get going.
Okay.
Hey, everybody. This is Emily Ann Team from Central Office. We're getting ready to start the annual family planning Polycom. We wanted to go around the table and introduce ourselves so that you knew who was behind the screen before we put up the PowerPoint. My name's Emily Yates. I'm the Reproductive Health Supervisor here at Central Office.
Janelle Anthony, Family Planning Quality Assurance Nurse Supervisor in Central Office.
Consuela Staten, State Resource Mothers Program Coordinator.
Hi everyone, I'm Maddie Kapoor. I'm the Adolescent Health Coordinator.
Hello everybody, it's VD Dave. I'm the epidemiologist here at VDH.
Wonderful, and we want to see which health districts are on the call. So I'm going to read through the roll call, and Janelle's going to mark, I think.
I am. I'm trying to get this chair. It's like blocking the camera.
Oh, yeah.
So.
Oh, good call.
Yeah, good call.
Janelle's going to mark who's here. I'll read it. So when I say your name, just let us know. When I name your health district, let us know that you're here. So Alexandria.
We're here. Hi.
Hi. Allegheny. Arlington.
Here.
Hi, Arlington. Central Shenandoah.
We're here.
Hey.
Hey, Debbie.
Central
Hey,
Virginia.
Janelle.
Central Virginia. Chesapeake.
We're present.
Hello.
Hi, Janae and Mary.
Chesterfield.
Chesterfield is here.
Hey. Hey, and Lisa Park just joined us.
I have Juanita
and
on with me.
Juanita's with us too. Thank you. Where did I leave off? Chickahominy. All right, Crater.
We're here.
Chickahominy here. All right, we got Chickahominy and Crater. Cumberland Plateau.
Cumberland's here.
Hello. Eastern Shore. Hampton.
Hampton here.
Hello. Henrico.
Henrico is here.
Hello.
Hi, Rashawn.
Lenowisco.
Good afternoon. Lenowisco is here.
Hey, Michelle. Lord Fairfax.
Lord Fairfax is here.
Hello. Mount Rogers. New River.
New River's here.
Hello. Norfolk. Peninsula.
Peninsula's here.
Hi, Peninsula.
Hey, Judy.
Piedmont.
Piedmont's here.
Hello, Piedmont. Pittstan.
Pitt Dan is here and Southside is here too.
Wonderful. Portsmouth.
Portsmouth is here.
Wonderful. Prince William.
Prince William's here.
Hey, Rappahannock.
Rappahannock's here.
Rap's here. Richmond City.
Richmond's here.
And the Richmond City Resource Centers.
Yep. Both. Yep.
Great. Roanoke.
Roanoke and Allegheny are here.
Oh, okay. Thanks. We got Southside with Pittstan. How about TJ?
TJ's here.
Hello. Three Rivers.
Rivers is here. Three Rivers is here.
Oh, yeah, we did see Ken.
Yeah, we saw you guys.
Virginia Beach.
Virginia Beach is here.
Hello. And West Piedmont.
West Piedmont is here.
Hello. And last but not least, Western Tidewater. I think they're there.
Did Norfolk come on?
Norfolk is here also.
Yeah, it sounded like I was gonna say they picked up.
Wonderful. Did we miss anybody?
Mount
Did
Rogers
anybody
is
hop
here
on?
too, Emily. Sorry.
Okay, Mount Rogers, great.
Orange County's here too.
Great. Thank you. All right, let's go ahead and get started then. So, as a reminder, this call will be recorded, and we have quite a few things that we want to go over today. We did the roll call. We wanted to give updates on Title 10 and the new rule. We wanted to go over the 2018 program data, look at our work plans for next year since we finally got our Notice of Grant Award. We want to talk about chlamydia testing, some media campaigns that have been going on. Hopefully everybody got their posters in the mail. Some upcoming training and updates about the Lark initiative. As a reminder, please your line. I think
we'll go and get the last
somebody
one. We weren't sure if we were open until 2 or... Okay.
Somebody for you, Shenandoah?
Okay, sounds good. All right, thanks.
I think somebody's mic is open. Yes. Thank you. Everybody just double check their mics. We will have time for questions at the end. Because our agenda is pretty full, I ask for you to hold on to the questions until the end. And Janelle and I will switch back and forth.
Central Shenandoah, check your, and we hear feedback. Check your mic. You're unmuted. Bath County. Whoever's wearing burgundy, you're standing in front of the camera. I'm going to call you out. Please mute the mic.
I think it's muted now. Yeah. Oh, man.
Okay. Sorry.
We can't take ourselves too seriously, you know. All right, you ready to get started?
Let's go.
Okay.
We're not.
What's that? Can y'all see the slides?
Not now.
Not now. Okay.
Not now.
Our IT support, Janelle, is going to help us.
No, we can't see. We cannot see the slides.
Okay. Thank you.
You might have to unplug and plug back in.
All right, I'll plug and then plug it back. Okay. So Title 10 updates. You may have gotten my email over the weekend. The courts have blocked the new Title 10 rule change. So you probably heard about the gag rule, which would have prevented us from being able to provide referrals for abortion services and would have affected the way that we did minor counseling and pregnancy counseling. Those rules were proposed by the current federal administration, but they've been blocked in the courts because they are not they do not line up with the Title 10 regulations that have passed Congress. And so that stops the clock on our need for implementation. It doesn't make them go away. It means that the courts are going to battle it out, and that can take a really long time. So my call to you is continue offering services as we have been according to quality family planning program requirements defined by Title 10 and the CDC. Do not change. Everything has been stopped in the courts, and we'll be waiting further guidance. We also wanted to just start it off with some mythbusters related to Title 10 because we hear them all the time when we're out at site visits. The nurse managers who attended the in-person nurse manager meeting may remember this game, but we're going to play this little game because we're finding that a lot of folks don't know what you can use Title 10 dollars for. So I'm going to ask these questions, and the folks in this room are going to answer them to the best of their abilities, okay? Because I know it's too scary for people in the districts to answer over Polycom, but y'all can, talk about it amongst yourselves. So true or false, you can purchase contraception with Title 10 dollars, like Larks. You can buy IUDs with Title 10 dollars.
True.
True. Yep, that is absolutely true. We get a lot of questions about that, like, hey, can I buy Kylena with my Title 10 allocation? The answer is yes. That is allowable. True or false, you can pay for family planning staff with Title 10 dollars.
True.
That's definitely true. That's what we spend most of the money on, is for our nurses and clinicians. True or false, you can purchase family planning medical equipment with Title 10 dollars.
True.
Totally true. Yep, you can get speculums, you can get privacy curtains,
LED
you can get like lights, anything that is part of offering family planning services. You can buy that with your Title X funds. It's allowable.
Colposcopy equipment.
Yes,
and
colpo equipment, anything related to providing these services are allowable under the grant. What about family planning trainings, like traveling to and from conferences or training registrations?
Yes.
True.
Absolutely. Yep. And so sometimes we get questions like, hey, there's this great training. Can we use Title $10 for that? If it's family planning related, absolutely. Last one, you can purchase pelvic models to use when explaining contraception to patients. So like where an IUD goes or where the Nuva ring goes.
True.
Totally true. So any educational materials like that are absolutely allowable, as long as you have the money. Okay, don't have Dave Crabtree call me to his office and I've told y'all could buy all these things. You got to check with your budget and make sure you can afford it in your Title X grant. Hold on one second. Oh, they left the
Dial it back in.
Okay.
Yep.
I'm going to unplug it and plug it back in because I think
That knocked us offline.
it knocked us off. Yeah.
The slides are not up on the screen here.
Yeah,
I don't know about
call
anybody else.
We got a phone call. It knocked us offline. Someone was calling in. We're putting them up right now.
All right, we're going to try again. There we go. Maybe?
Hold on. It should.
There we go. It's coming.
Yeah, it's trying.
I don't know, Janelle.
It did say sending content.
Yeah. Let me stop it and try it again.
We're having technical
I
difficulties.
don't know.
Hang on one
I'll
second.
send it. I don't know who registered for that district. I'll email them. Pull it out again.
Pull it out. Count to 3.
That's what IT tells you.
I know. Maybe.
It's like it's not.
Sorry about this, guys. I'm going to go ahead and mute it so that we can figure it out. Time out. Let's try this again. Nope.
Yep, it's coming.
Yes.
No, what in the? What's going on? Okay.
Can Rich Watson help?
Rich, can you hear us?
No, I think we're.
okay.
I think you're okay. You just have to make it go back to the.
Okay.
Can everybody see now? One person. Can everybody see now?
Yep. Yes, we can see him.
Okay, thank you.
Just not like
Yeah, you just
a
got to go back
slideshow?
to your current slide. Just from current.
Yeah, that's what.
Oh, that's when it's not picking it up.
Yeah. Janelle.
That's okay. Just do it again.
We'll just
back out.
Yeah. You can just do it from the.
Yeah.
Well, we'll just do it like this.
You can zoom a little if you want.
We're gonna try it one more time because this happened before. Sorry, guys. I'm gonna mute it again. Okay. Teamwork. Okay.
Please, no one else call in.
Yeah. Yeah. Somebody tried to join and it knocked us off. Okay. So all of those things that we talked about are true as long as you have the money. So if something stood out to you as like, oh, I really need that for our Title X program, I really encourage you to talk with your health director and your business manager about those needs. Did they know that you need those things? We find a lot of times the clinical staff will tell us that they need these things, but the business manager didn't know or the health director didn't know. And so there are a lot of assumptions made. And then they, like at the end of the day, they didn't have what they needed. Do they know that Title X funds can be used to support these things? You know how VDH is? It's a game of telephone. There's a lot of misinformation. And so if you've heard a health director or a business manager say that any of these items on this slide are prohibited, you know, feel free to share this information with them or send them to us, and we can show them how in the grant those things are technically allowable. LHD budgets have been submitted already for this budget year, but they can be modified as needed. So say you have a vacancy that you didn't expect, that money needs to be reallocated somewhere else. And that may be an opportunity for you to look at your budgets and make sure you have what you need. So just throwing that out there. Now, let's look at the data for Title X for the past 4 to 5 years.
Excuse me, before you go.
Yeah.
Before you go on, when we need to do like a reallocation of funding, like just like say for instance we do have a vacancy and we can maximize those dollars, i.e. getting Larks or getting some type of equipment, do we need to send in a formal request to you to move those dollars to a new category? And then if we do, what's the timeline?
As soon as you know, you'll want to submit that request, and how that would go would be you would work with your business manager to redo your line item budget and have your new budget reflect how you expect to actually spend the money, and then just a little paragraph to explain why that was needed, and then that would be submitted to me and Janelle.
Okay, thank you.
You're welcome. Okay, now let's look at the Title X data. So we saw a total of 38,021 patients during 2018. You can see through these trends that we've seen a steady decline in patients for the past 5 years, with 2014 showing almost 61,567 patients, and then 2018 we're down to 38,021. Most of our patients are female, 36,872, which we expect. If you break it down by age and gender, you'll find that most of our patients for this past year, just like in previous years, are in their 20s, followed by folks in their 30s. And then the teens and folks above like 40 and up are about the same proportion. For female teen clients, this is a breakdown of the patient data for the past 5 years. You'll see that most of our female teens are older teens, so young women who are 18 or 19 years old, followed by folks who are 15 to 17 years old. We saw 518 young women who were under 15 last year. These trends mirror previous years, but we do still see a decline over the past 5 years. When you look at male teen clients, the males they show different trends, perhaps because the sample size is smaller. You know, we don't have as many male teens as we do female teens, and so the data bounces around a little bit more. This past year, we saw 96 male teens between 18 and 19, followed by 50 male teens 15 to 17, and 33 who were under 15. Huge difference between the female teen clients on the previous slide. When we look at income level, this is one of the things that I think makes Janelle and I most proud of our program, is how many vulnerable patients are served by our Title X program. 64% of our clients are 100% FPL and below. The majority of our clients are below 200% of the federal poverty level. So this really shows that we meet the needs of the most economically vulnerable patients. This is different from other Title X grantees. Many Title X grantees so the threshold for the Title X program on the federal level is at least 50% of your clients must be 100% or below FPL. And many grantees struggle to reach that, but VDH does not struggle to reach that, which shows that we are consistently a safety net provider for the lowest income Virginians. And when we look at insurance status, we see the same thing. So I know there's a lot of information on this slide, but the information furthest on the right is the information from calendar year 2018. 67% of our clients were uninsured. So even though we've had a decline of clients over the past 5 years, you'll see that the percentage of uninsured clients has stayed the same, which shows that even though our patients' numbers are going down, we're still meeting a need, an unmet need in the community. 15% of our clients use a public insurance program like Medicaid. 18% were shown as using private insurance. I'm curious about that one, I'm curious about that one and would like to hear feedback related to that. So when you look at the primary contraceptive use among female clients, again, this slide has a lot of information. This is the number. The next slide will show percentage, which I think is a little easier to tell. But we saw that over on the right-hand side, just shy of 8,000 of our patients use the IUD and implant. That's almost as many as use the shot. So we're seeing an increase in patients using Larks compared to previous years. We saw about 12,000 patients use the pill, patch, and ring. 4,000 use condoms, and then a pretty good percentage use other. That includes every other method that we have in WebVision. We all just put those together. When you look at percentage, it's easier to tell trends. So in calendar year 2018, we saw that 21% of our family planning patients used Larks. So 21% used IUDs and implants. 22% used the shot. 33% used the pills, patch, and the ring. And 11% used condoms. So we've seen the percentage of folks using the shot go down over the years. The percentage of people using Larks go up over the years. And pills, patch, ring is going down too. So what does this tell us? I want to open it up to the floor. Yeah, I mean, you can answer, Janelle.
Oh, you want me? The districts?
I was really thinking the districts. Okay. But if you have an idea, yeah. Janelle's looking at me like, I have an idea. Janelle, do you want to go ahead? Go ahead.
This tells us we need to think of innovative strategies.
Why do you think that? Do you want me to go back to a slide? No. In particular? No?
Oh, man. Our numbers are decreasing.
Yeah. Let me go back to this first one.
Our numbers have decreased significantly. So we're not meeting, perhaps we are meeting the need. We don't know. I mean, we need to
what
think
is
of
the
different
percentage? This is Debbie. What percent of decrease is it, and how much of that might relate to fewer visits because of increasing the proportion of people using Larks?
That's a really good question. I can't really figure that out, but I think that is fair to think that has a part of it. You know, with the PAP guidelines changing and with an increased use of Lark, people may not be coming in as often.
But I think that could possibly be an innovative strategy. I mean, maybe we can see, maybe a district could say, let's find out where people are going or what's happening. So that would be something that could possibly be innovative. Mm-hmm. We're not saying that people are doing a bad job, by the way, because the numbers are decreasing. No, that's not what we're saying.
It's a definite trend that I think we need to talk about.
We also have a factor.
I wonder if Medicaid expansion is going to make that decrease even more, particularly in the income A.
I wonder. So let me move ahead a little bit to these slides for insurance status. So most of our patients are uninsured. 67% are uninsured. 15% are private, or public, sorry. And so I wonder if we'll have fewer uninsured patients and more Medicaid patients, or if those newly eligible for Medicaid will go somewhere else, if there is somewhere else to go.
The other problem
they are going to be provided an advantage to, I won't say an advantage, but they will be provided with the opportunity to go to a private PPO. So it may be we may lose clients to private PPOs.
It's possible. And if this is the landscape that we are moving forward into, I think we need to talk about who should we be serving. The Medicaid expansion isn't going to pick up everyone in need. And so should we focus on the folks who are not eligible for Medicaid expansion, not eligible for any kind of safety net programs with the lowest incomes? Like, should we, I guess, just be more strategic about who we're targeting? Because now people have more options. If they have Medicaid, they have more options, theoretically.
And I think we are going to have to be more strategic, because I don't think Title X is going to keep giving us money and our caseload's decreasing. Like, we're going to have to come up with something.
That is one thing. We keep asking for Title X money, and what I talked about with our project officer was this, like, these numbers. Like, they're like, what's going on there?
Yeah.
Right?
This is Debbie from Alexandria. The other thing we believe, but we, again, don't have documentation of this, but our undocumented people we're seeing a decrease, or people calling and canceling appointments or not making appointments, not just for family planning, WIC and other things, for fear of coming to a public agency.
Yeah.
Leaving them less served.
Whew. I've heard that from other health districts too, Debbie. And I believe that's part of it too.
This is...
Go ahead, Dr. Rashheim.
Yeah, I was just going to say that, one thing, and this probably varies by, where you are in the state, is that we have a large population here of undocumented residents, and these people, are not eligible for Medicaid. And so, I think that those, at least here, I think those numbers are probably going to stay, where they are. So, even with Medicaid expansion, that's not really going to apply to those people.
I agree. VDH still absolutely has a role in the safety net, as you're seeing. Not everybody is going to be wrapped up with these, like with Medicaid expansion or the expansion of other safety net programs. And so we share this data to invite you to be thinking of where your role will be in your communities given these trends, and how we can be proactive at reaching patients who aren't currently accessing our services but could really benefit from them. So it sounds like, Dr. Roshheim, in your area, there remains a need for undocumented communities. And so perhaps that needs to be where folks in your region focus. And then in another region, there may be other folks. Thank you for that.
I would definitely agree with that. I mean, I'll give you just an example. It's not a family planning example, but I think it does make the point, which is that we have a maternity program, and we do not advertise at all for our maternity program because we don't need to. Our maternity program, we serve a population that is very much in need of service.
Mm-hmm. Absolutely. Thank you. So we will absolutely, so these slides will be posted online on the intranet, and Janelle also sent an email with all these slides too, so you will have this data for you to look at as many times as you like. I'm going to move ahead to this slide talking about innovative strategies, which is what we've been talking about. We've got to really look at our clinical processes, scheduling practices, figure out any bottlenecks there, figure out the role of VDH clinics, and consider establishing some clinical sites outside of health department walls, because clearly, based on the data, fewer patients are coming to us. So where are the folks in need, and how can we go there? 2 health departments are partnering with public schools to offer family planning programs. Richmond City, shout out to them, who've set up some resource centers in low-income housing communities. We've got Central Shenandoah partnering closely with community centers. We've got a couple mobile units out there taking the services to the people. If you have any ideas and need money for these kind of things, please let Janelle and me know, because we want to see these trends change. We want to see our program remain impactful. And if your patients are telling you you need something in order to meet the needs, we want to hear about them, and we want to figure out how to get you the resources to do that if we can. This is a good job, Janelle. She added this picture.
That dawn was flowing.
I'm sorry, that caught me off. That caught me off guard. Woo! So I sent out an email this morning to nurse managers and health directors that we do have supplemental funding for Title X projects. Awards amounts will range from $1,000 to $50,000. The idea for the supplemental funding is one-time expenses related to projects that will meet Title X priorities and expand access to quality family planning services. At this link in this slide and in the email that I sent, you can find all the instructions for how to apply. We will score all the applications we receive according to the criteria we've listed. Some examples of neat projects in the past for this type of funding has been for equipment. So folks who need like a facelift for their clinical services, if you need some fresh speculums, if you need fresh equipment so that patients can receive better care, then you could use this for that. Central Shenandoah used some funding to start a teen community center where they're doing referrals for family planning services. Another health department did an intensive needs assessment, and they determined from their analysis that their health department is located in the exactly wrong location for their patients, because they found that their patients were coming from a different place. And so as a result, Hampton Health District is doing some outreach differently using that information. So be thinking about things you could use this money for. The applications are due May 31st.
I think May 31st.
May 31st. Had to think for a second. It's not a very extensive application. May 31st, yes. The funds need to be expended by March 31st of next year. So this can't be for some ongoing stuff. The money has to be gone by March 31st. Not joking around. I cannot grant.
I'm itching to say it.
Go ahead.
When we go on site visits, so many people tell us, oh, we need this, we need that. And I don't know how many times Emily and I have been like, oh, awesome, we have supplemental funding. No one applies. Or you guys bug us, and then, no, I'm sorry, you don't bug us.
Stop it.
I love you guys. You guys ask, and then you apply, and then you can't spend the money. So please make sure, whatever it is, you can spend the money by March 31st. And if it's something that's less than $1,000, you will probably be denied. I'm joking.
Stop. No,
we
you
will
should
help you.
still
We'll
ask.
probably, yes, please ask, because we may be able to help you look at your own budget and figure out like where you could do that. But if not, we're open. It doesn't necessarily have to be a minimum of $1,000. Just reach out and ask if you're unsure.
Mm-hmm.
I love you guys. Totally joking, teasing you.
Another strategy that we are doing is inviting community agencies to participate in the Title X funds. To be clear, local health districts are still getting the same amount of allocation. So $2.7 million of our Title X grant is earmarked for the local health districts. This money is not coming from your bucket. We received more funds this year, and we are planning to use those for additional training for local health districts and to invite community agencies to join our network so that we can reverse the trends in patient decrease. So those community partners that you know are seeing patients, if you think they would like to receive Title X funds, please encourage them to apply for them. We're going to release a request for applications. The goal of these applications will be to increase access among women in need. We'll let everybody know when the request for applications is released. And we hope that you consider encouraging your partner agencies to apply so that they can get some funds as well. All right, I'm going to turn it over now to Janelle, who's going to go through the work plan.
So the 2019-2020 work plan is not very different from the work plan that you guys had for the 7-month project period. Emily and I try very hard not to change your work plans too much. We try to keep it like as close to similar as the previous year or project period as not to cause confusion. So when you look at the work plan, you'll see the goals have not changed. Offer quality family planning services to vulnerable patients. We're still supposed to be providing quality assurance / improvement. That's a big focus of this new grant, quality assurance and improvement. So we'll talk about some of those activities we'll be doing. And then promote family planning services through community awareness, participation, and collaboration. The current work plan has been uploaded to the family planning intranet, and it's in RedCap. We're going to try something different. RedCap is good because it lets Emily and I track who's doing what, when people are turning things in. We can just run all kinds of reports that we need. So that survey will go out today at 3 p.m. So at the end of this webinar, or Polycom, I'm sorry, the link will go out. And it'll also be due on May 31st at 5 p.m. So.
Do you want me next slide?
Yep, next slide.
Okay.
So the way that we're going to achieve the goals in our work plan, again, this is very similar to our 7-month project period. Clinical data, we're going to be monitoring Tableau. We've created a family planning dashboard, which we'll talk about. We're going to have you guys do quarterly surveys that you've already been doing. That's not going to change. We're going to continue doing our technical assistance calls every 2 months. We're planning for in-person trainings. We're still waiting to get our training person, which we'll also talk about. Yeah. Online trainings, site visits, and medical records. So audits. So all these things that we've been doing, we're going to continue to do. Just there's some new activities that'll fall under each one of those, I guess.
And what happens is every time we apply for a grant, some of the grant priorities change. And so like Janelle said, we do try to keep, I mean, none of this is new activities. What'll change is how me and Janelle present it to the feds. And so that's why there may be just some tweaks that Janelle will talk about here.
Yes. So in 2018, at our level, like Emily just said, some of the things that we said to Title X that we would accomplish would be to hire a family planning training and education coordinator. And that's...
I'm so grumpy about it.
Emily's...
Y'all know how it is. Hiring HR, like, it's really hard to establish a new position. But I think it's finally going to go out, like, in a couple weeks. So if you know someone with a great attitude who will help us train and educate, send them our way. It'll be posted soon.
And I'll have to supervise you. So if you're a baby, don't apply.
Hey!
No, I'm just joking. I'm just joking, you guys. I'm teasing you. Text reminder system. Lisa's in here, so we're going to put Lisa on the spot in a second. Yeah. Family planning dashboard was completed. The family planning STI form revisions have been completed and have been piloted and are being redone, right, Dr. Adekoya?
Oh, that's right, Dr. A's here.
Oh, yeah, we're saving you.
Well, we're going to have, we're going through final edits.
Okay.
And then set up a training date by Polycom and make sure all the T's have been crossed.
Okay.
Okay.
So those forms are in the final stages. Fertility awareness-based methods training, that should be ongoing. Project Connect, we're working on. And,
yeah, remember that?
And CHW A collaboration we're also working on. Lisa, do you have any updates on the tech system? Okay.
So the formal policy to support the texting has been approved probably about 2 weeks ago. So now we've got to revamp the consent forms, to include the language that has been suggested.
Yeah, that makes sense.
So the technical piece of this has been done for over a year. Mm-hmm. So right now, I mean, none of us have seen it for almost a year now. So OIM's got to go back and look at all of the programming stuff and how it's supposed to work and come up with the instruction manual. It's got to go through the whole QA process because it has not been through the QA process at all. Okay. It's got to go through QA, through some limited testing, and then training, and then roll out. Okay. It's not rocket science, but we just want people to be familiar with how it goes. It's fairly intuitive. Yeah. Again, but I haven't seen it in nearly a year. Yeah. Run through it, so we'll have to, put it through its paces again. So my goal is to have it out by the end of May. If I had to guess, it'll probably be closer to the June time frame, but it's moving in the right direction.
Excellent.
So some of the sticking points have been unstuck.
Maybe the family planning training and education person is the same place that the text system is. They're all like, because it's been a year for that too.
Trying to get that. Thank you for that update.
Thank you, Lisa.
We're hoping that the text reminders through WebVision will help with no-show rates. Marion?
We have we just have a question. You guys were moving a little quickly here. So what's the status then of the text reminder system? Is that like just in limbo right now? And also, what is this family planning dashboard?
So the family planning dashboard is that thing in Tableau that shows you
encounters
and like breakdown of income, and
it's just like the STI dashboard except it's family planning
one, the one that Bill Edmonds made.
Okay, so are you just all right? Are you talking about just like the Title X reports?
No.
Oh, okay. I didn't know that. I'm gonna have to look for the dashboard. I didn't know there was a dashboard in there.
Why don't we send out that link again? Bill Edmonds worked with us to create a dashboard that summarizes a lot of the stuff that's in the Title X reports. Marion, I know that you look at those Title X reports and know them back to front. What this dashboard does is it summarizes them so it's really easy to understand.
At a glance.
Yeah. So it won't be any new information. It's just a new tool for you.
And it should look similar. So the same folks in OIM that put together the STI dashboard for us as the same folks that put together the family planning dashboard for us.
So we'll have to send that. We'll send that link out. We'll add it to the notes.
OIM did a great job. The data warehouse guys did a great job.
Okay, thank you.
And the text reminder system,
Emily?
again.
Hold on a sec, Dr. Rashad.
Marianne, the text reminder system, we're hoping to have it rolled out by the end of May or the middle of June.
All right. So those are. Yeah, go ahead, Dr. Rashheim.
What is Project Connect?
So Project Connect was a training that we did years ago that was reproductive coercion training. It is in desperate need of a facelift. It's like an older training that's really long. So folks will be like, oh yeah, that really long training that we did. We haven't offered that in a couple years. We're working with injury and violence prevention to streamline it so that it's quicker and easier for districts to do. And that is something that we're working with them on the central office level. And so people won't have to take that really long training anymore. Instead, the training will be shorter and more effective.
More culturally correct.
Yeah.
Because it's heavily focused, it's a heterosexual curriculum, and so it needs to be updated to reflect LGBTQ.
Different relationship dynamics and stuff.
So
thank you for asking.
Sure. I also think that would be a very good idea to send out the dashboard link, because I don't think that I'm not sure I've ever even seen that.
Yeah, we'll send that out.
Hi, this is Henrico. I have a question about the family planning STI form revision. What is the estimated time of that?
Hold on. I'm going to cut you off. Can you hold your questions to the end? Because we asked in the beginning to hold the questions. We want to try to get through the work plan and make sure, or get through the rest of the presentation. So hold your question for us until the end, and we'll come back to you, okay?
Does that work, Henrico?
Yep, son.
Okay, cool. All right, next slide.
All right, so again, the work plan, when you look at it, shouldn't look too different. But some of the things that Emily and I said that we focus on, you guys have heard before us talk about the regional in-person family planning orientation trainings. So we're waiting for our training person. In the meantime, we have created a orientation checklist and skills checklist as part of the manual revision. We were hoping to have the family planning manual ready for you today, but we just couldn't do it. So, and we want to make sure we do it right and that we have time to go through some of the changes with you guys. But there is an orientation checklist that's going to be in the training section now, as well as an annual skills checklist. Can't get my words out. Of course, we're still going to try to do a family planning summit. It's not going to happen next year, but probably the following year, so year 2 of our 3-year grant. We're revising the family planning manual now. As Emily stated, we're working with Injury Prevention and Violence Prevention Program to provide coercion/human trafficking training. So they currently do have a training set up. We're working with that team to figure out how we can piggyback off of that. So, of course, we'll let you guys know as soon as we know. And lastly, one of the focuses of our work plan this year is increasing our chlamydia testing among females under 25.
And so this is where y'all come in, because a lot of the stuff that we've mentioned are admin things that we need to do here at central office. The chlamydia testing, though, is a great opportunity for local health districts to correct some of our numbers. So Janelle, what do you have here?
So, I mean, this is pretty much what you should be following for chlamydia testing. If it's a female under the age of 25, she should be getting tested. That's the recommendation. That's best practice. If she's not being tested, why? So, I mean, we need to just make it the norm to test our clients that are under 25.
So how do we compare to other Title X grantees when it comes to chlamydia testing among women under 25? Not great. The majority of Title X grantees test 81 to 90% of females under 25. We're in the 61
to 70% range. This is among 15 to 19-year-olds,
Yeah,
though?
they don't have it broken up by, it's 15 to 19 and 20 to 44.
That stinks.
So it's kind of misleading.
So if you look at sorry about that. So if you look at Region 3, which is includes Pennsylvania and Virginia and like everything in the middle, most of the grantees test 61 to 70% of females under 25, and we're in the 31 to 40 range.
So these are our counterparts, you guys. These are the people that are in the same geographic region that we are. This is who we get compared against. We had a call with Title 10 maybe a month or so ago, and, you know, everyone got called out, and that's where we're at, you guys. So Emily and I just had to sit there.
Because if these are the guidelines, it's really hard to explain this, you know? And so here are some strategies that we've been given from the national office to increase testing.
So there's an awesome toolkit, Chlamydia toolkit, put out by the Family Planning National Training Center. Please take a look if you get a chance. But basically, to summarize the toolkit, some of the things that we should be doing is including chlamydia testing as a part of all visits. So not just our annuals and initials, but really it should be a part of depot visits, birth control refills, pregnancy testing. In addition to orientation checklists and annual skills checklist, we created a new medical record audit tool that will be in the manual, the revision. And this tool is not to replace the DBE tool. This tool is for Title 10 audits. So this is the stuff that Emily and I look at when we come out and do a site visit for you. If you've had a site visit with us, you guys know I tell you all the time, I don't care about labels, and I'm not looking at that. I'm looking at like the Title 10 counseling and how that looks. So this tool will help you perform your audits and make sure that staff is counseling like they're supposed to, that they're documenting everything that Emily and I would be looking for. It's taken straight out of the program review tool. Perhaps the biggest thing that we've heard other grantees say they've done to increase their numbers is to normalize language. So, you know, again, if you've seen me on a site visit, I've probably said this to you. We recommend screening much like we recommend immunizations for clients your age. So just make it normal. Don't say, do you want to be tested today? Because most people aren't going to think they have chlamydia. Most people don't think they need to be tested. So really, we shouldn't be presenting the question that way.
I really like the second one. Like, I talk to all my clients about chlamydia screening. Preventive health is so important.
So that's
almost this is part of your visit today.
Almost like Project Connect, if you guys remember. Normalizing with Project Connect. I talk to all of my clients about intimate partner violence. So just making it normal. Lastly, we ask everyone if they've been screened at every visit. So again, just not singling the client out or making them feel defensive or like you're trying to judge them. It's just making a normal part of the visit.
And to be clear, clients always have the right to decline. So we're not talking about like compulsory, forced chlamydia testing, but how can we bring it up in a way that makes clients more open to the idea and not feel stigmatized by it?
So the other biggest thing that we have heard from other grantees is using opt-out language has really helped them increase their numbers. So I recommend a test for chlamydia and gonorrhea to all my clients under 25. Chlamydia often has no symptoms. While you're here today, we should screen you if that's okay with you, and unless you've been screened recently. So again, if you see we're not making anyone do anything, we're just kind of normalizing it and making it so that they have to say, no, I don't want this test. Like HIV testing. And lastly, untreated chlamydia can lead to infertility or the inability to have children. The test is simple, and all we need is a urine sample or a self-swab if you do that. If it's okay with you, let's go ahead and get you tested today.
Mm-hmm. Key is if that's okay with you, you know, always it's got to be okay with the patient, but sometimes it's how you present it.
Yes. Please hear us say, if it's okay with the patient. Emily and Janelle are not telling you have to hold people down and test them for chlamydia, but we should be offering it.
you should offer and educate.
Right. Just like the Plan B, offer it, and if they don't want it, they can say no, thank you. But we should present it in a way that, I guess, lends itself to testing.
No one thinks they have anything ever. Like,
right.
So. Okay, a couple other exciting things. So we launched the Whoops Proof Media campaign, but by this time, all of the nurse managers or nurse supervisors should have received some rack cards and posters for the Whoops Proof campaign. This campaign is designed to increase public awareness and positive regard about the most effective methods. Here's a bus shelter ad. Sorry to the guy who's in the bus shelter.
No, they like
has
them.
To be
I totally was gonna. The guys in our office have hung these posters. They love
It's
them.
true.
I was gonna try to
The
snap
gentlemen
pictures,
in the office
but
are really excited
yeah,
about these posters.
They love the posters.
We do have extra posters, so if you want more, let me know. I've got a small stack, and they're just sitting in my cube right now.
Get the permission of the guy sitting there.
That was from the
Communications team. Yeah, that wasn't. They should have.
Emily Yates Washington.
I'm just wondering.
You can see his face.
Was it some random guy sitting
Wait,
there?
Yeah, I think it was some random guy. But
Don't focus on that, y'all. We're gonna move on. So here's some of that. We have digital versions of all the ads too. So if you want to run them on social media, you may do so. I need to mail you though the jump drive because I can't send you a zip file. So shoot me an email. Let me know that you want some, and I can mail them to you. And these are what some of the ads look like. And when you click on it, you go to a page that lets you type in your zip code and then determine what family planning clinic is nearest to you. These are some of the posters. Okay, to the trainings. This is Janelle's slide, as you can tell.
Oh, everybody loves the trainings. So, just a couple of things before we get started. Again, as Emily and I kind of mentioned earlier, you guys, we're working under a work plan as well. And we try very hard not to have you guys do things just to do them. If there's something that we can do at this level, if there's data that we can look at, we try very hard to do that. So please know if we're asking you to do a training or a report, it's because we can't capture that information up here. I don't think we ask a lot. So just please be mindful. I had a few people email me after March 31 asking about trainings. The grant's over. So it's really not helpful if you do those trainings, you know, April 8th. It's got to be done by March 31. Having said that, Title 10 has changed the trainings this year. So previously, trainings were, you're fine, you can leave it there. Trainings were due once every project period. Now, as a part of quality assurance and improvement, they want the trainings done every year. So all those mandatory trainings that we used to have for you guys, Title 10 is asking to have you do them every year. But Emily and I know how ridiculous that is.
So dumb.
And that I should have had the meme that says, ain't nobody got time for that.
Yeah.
Because that's, I mean, we know no one has time to do that.
It's the same training.
And they're the same trainings.
That's silly.
So what we're going to do, our workaround for that is everything that you need to be informed of during the project period is in the family planning manual. So by you reviewing the family planning manual and signing the page, signature page, you've been informed of the training requirements, and you're not going to have to do any kind of online trainings related to like voluntary participation or abortion or pregnancy counseling. All of that will be in the manual. Now, if we have trainings that come up that we think may be beneficial to you all, we may require those, but for now we're going to use the manual as our way to say we're meeting that goal. The signature page has been revamped to say, I am aware, I've been informed of voluntary participation, all of those things it's going to call out, and we're going to have you guys continue to upload those into REDCap.
So signing the signature page for the manual will meet this requirement.
And it is mandatory for everyone.
So we've kind of got to be, because the feds are telling us that everybody has to do this annually, Janelle and I are going to have to just be like really good at making sure the signature pages are submitted. And
so
this way, you won't have to do the same training again.
If the signature pages are not submitted, we're going to have to go back to the trainings. So please, I don't enjoy doing the trainings any more than you guys do. So please, please, please make sure you're getting the signature pages signed by anyone that's working in family planning, health directors, nurse managers included. It has to be signed by everyone working in family planning. As far as the review of the manual, OSS staff only really needs to look at the administrative section. I have to go through, but I don't think there's anything other than the admin part that they would need to review, but everyone else needs to review the manual in its entirety. And we've actually cut out quite a few pages, even like more than the manual is going to be even a little smaller than it was before, because now we're kind of having time to really go through. You guys know the first manual was like do or die because we were having our site visit. So moving on to our trainings for 2019, 2020. Oh, that's crazy. So one of the things Emily and I are very excited about is we're planning a family planning health worker certification training for nurses and health educators. There's a few reasons why. One is because we've heard during site visits that clinicians sometimes we're seeing a duplication of counseling. So we'll see the nurse does the counseling and then the clinician does the same counseling. And when we ask why that's happening, sometimes clinicians say, well, I don't know what they're really counseling on and I want to make sure the client gets everything. So we kind of figured the best way to make sure the counseling is standard is to have a standard training and have people get certified. So this will only be for nurses and health educators. This is not for clinicians. We got to get to the point where clinicians are not doing counseling and they're practicing like they should be and the nurses are doing the counseling. So this course is a 2-day certification class. It's comprehensive on contraceptive counseling and education. You guys will learn how to integrate STD prevention messaging. You'll learn the latest motivational interviewing strategies. The certification is optional. So at the end, and it's all covered. You don't have to pay for the certification. We're paying for that. But if you want the certification, then you have to submit a video of you doing a mock counseling session and submit it to the provider of the, thank you, I'm trying to think of what their names are, and they will certify you and you'll get a certificate. If you don't want to do the certification, and the certification would be good for 3 years, if you don't want to do that, you still get continuing education credits for doing the training. So we're trying to do, I think, 4 or 5 of those regionally, and we're trying to get those set up. As you can imagine, it's a lot of work, so we'll get the dates out to you guys as soon as we can.
And we'll do it throughout the state. And so hopefully you can get the one that's closest to you, but you'll have all the dates in advance so that you can spread them out and make them work.
So this will kind of take the place of the summit this year. This, and for the clinicians, the 2020 Essential Access Conference. So the same group that's putting on this health worker certification, we'd like if we can get some clinicians out to this conference. It's in LA in February. I think it's a 2-day conference, especially clinicians who may not be comfortable with IUD insertions, or if you're interested in having an advanced IUD insertion training, they'll be offering those. The first day is going to be all-day IUD insertions. So if that's something that you're interested in, just keep that in mind. We'll be sending information out when that's released. As I mentioned to you guys, we put in an orientation and annual skills checklist into the family planning manual. We still have contraceptive technology CEs available, CEUs.
We sure do, yeah.
If we had some people go to a contraceptive technology conference with supplemental funds, so if that's something you guys are interested in, you can send in your application and request that. So yeah. We still have our technical assistance calls. Those are the dates. I believe on the last call, I told you the July meeting was July 17th. It's actually the 16th. It was correct and trained. I just had it wrong on my presentation. So those are the dates. They're in train. Nothing changed there.
Oops.
No, you're fine. All right. Lark Initiative updates.
Yeah, this is our last update before Q&A. We have done so well on time. Oh my gosh. So the Virginia Lark Initiative was the TANF-funded initiative. It's a pilot program that offers free hormonal IUDs and implants to women up to 250% of the federal poverty level. 12 agencies received these funds. We'll go over those agencies in a minute. Many of y'all have been partnering closely with them. Our communications team made this promo video, and I want to play it for y'all. We have, I sent this out to health directors a while ago, but I can send it out to anybody who would like it so that you can share it. I'm going to play it. It's just a minute long.
That's good.
Cute, right? So if you go to the VDH website, you can click on free birth control, and it'll take you to a web page that lists all the agencies plus the Title X, like a little clinic finder for Title X. So they will be directed to local health departments and agencies receiving these Lark funds. Janelle and I had the honor to talk about the Lark Initiative at the American Maternal and Child Health Programs Conference. VDH let us put a superhero on the poster, which I feel really proud of. We wanted to have some fun with it because it's been so much work to get this program off the ground and been the result of a large number of organizations working together. So here's a picture of our poster. We were too vain to put a picture of us. We didn't like how any of them turned out. So this is the poster. So this is the breakdown, I know it's kind of hard to see, of how many encounters have been covered by this program since it started. Now, be mindful that the contracts began on October 1st, and not everybody had submitted their invoices by this time, okay? But at the end of March, we had data on 582 encounters. 408 insertions were supported through this program. 42 reinsertions were supported, 132 removals, and 446 devices were purchased. Now, if you're doing quick math, you're like, why don't the insertions and reinsertions add up to the devices? Y'all know sometimes it gets weird. You know, I've had a couple people tell me that there was a patient who had Medicaid. They billed Medicaid for the Lark was sent and then lost it. And so they didn't have coverage for the actual insertion. So they had this Lark assigned to them, but nobody to pay for the Lark to be put in. That's happened a couple of times. So this program has supported the procedure rather than the actual device. There are funny things like that that happen that explain why the numbers don't add up perfectly. Here's a breakdown of the patients who we saw as part of the program by the end of March. 355 of them were not Hispanic or Latino, 198 of them identified as such. Most of our patients identified as white. 53, though, did not respond to the race question, which is important to capture. A lot of people don't like to get that information. 130 identified as Black and African American, and 47 identified as some other race. When you look at income, the majority of the patients seen through the Lark Initiative are at 100% of the federal poverty level or below. We do have a pretty good number, though, between 150% and 249%. So it's getting those folks that maybe make too much for other safety net programs, helping them out. And this is a breakdown of where the patients live. So if it's highlighted in blue, at least one patient indicated that they lived in that county, even though the provider may have been outside of that county. This is where they said their residence was. In the darker blue, the counties and cities have a higher concentration of patients. So we are seeing some of rural Virginia being captured by this initiative, and we do anticipate more folks being captured. Unfortunately, we do not predict far southwest Virginia to be covered at all, because the furthest west we have is a provider in Roanoke. We are doing another call for applications as soon as possible to invite other providers to participate in this program. And so we'll send out an email about that. If you know providers who would like Lark funding, it's only for certain Larks, okay? And local health districts, y'all have a stock of Larks. So this is for folks who don't have access to these Larks. If you know of anybody, send them my way and they can be part of the project.
All right.
Last thing before our Q&A.
So reminders, we're coming up on 340B recertification period. So if you guys remember, the period for Title 10, STI, and TV they're all on the same schedule now. So that's going to start on May 13th, and it's going to run until June 10th. They're going to do their annual recertification webinar on May 8th from 1 to 2. Please make sure that you go in and check your authorizing official and your contact. Authorizing officials should be the health director, and the contact should be the nurse manager. If you need help with that, please reach out to me and let me know. CC Emily. We will, usually what happens is once the period opens, I start a spreadsheet and I keep track of who's recertifying. And sometimes you guys aren't so nice when we reach out to you, but we will be reaching out to you if it's getting close to the date and we see you haven't recertified.
The reason it's not hard to do. It takes about 5 minutes to do, but the reason we reach out so often is because if you don't do it, it means you can't provide 340B medications.
Right.
And that is a big deal.
Yes.
So me and
Don't.
Janelle are doing our jobs, even if it's annoying, to make sure that you recertify. For real.
I feel like we're helping you, because it doesn't really hurt us, but it knocks you out of the system. And if you wait to the last minute to make those changes, it doesn't go through automatically. So you really need to go in there before the recertification period, so that if you have to make changes, you have plenty of time. We told this story last year. We had a district who shall remain nameless who almost gave us a heart attack because they literally waited until the day of and then couldn't get their information changed. And I think I was off at home trying to help them. Like, we were doing it by paper. Okay, 2 years ago.
I was at my surgery.
Yeah, it was a
So
terrible
where
time.
do we go to? I'm sorry, I haven't done this before. Where do we go in order to do the information and such? Or do we wait for the webinar?
Email Debbie, because I don't know. It's the 340B website. I mean, you could Google it, but if you send me an email, I'll send you the link.
We'll send you the direct link.
Yeah.
Okay. Thank you.
Sure. And just remember, this doesn't impact only your contraceptives. It also impacts your STI meds and your TB meds. So the implications are significant if you miss that deadline.
And we cannot do anything for you. If you miss it, you will have to wait until the next period.
It's one of the tough things. It's like me and Janelle can't help you.
So when we email you, it's because we're trying to keep. No.
Are there different? So one you do recertify once, and that'll cover all three.
Yes.
Thank
so
you.
If you no, it's no. I'm sorry. You'll get the emails at the same time. You'll get 3 emails at the same time, but it's 1 email for each program.
So it's not a repeat.
Okay, that's what I thought.
So
okay,
pay
thank you.
attention. Yeah. I'm sorry. Yeah, because it used to be different periods of time, but now they're all going to come at the same time. So you will get 3 separate emails. Please don't think, oh, I did it for one, that's all. You're going to have to do it for each program.
This is Brooke from Rappahannock, just as an FYI. Having been through this a number of times, the delay comes in if you need to change something. So, for instance, if the grant number changes, something like that, that's where delays tend to happen. So as long as all the information is the same, the process is actually pretty painless.
Yeah, thanks for that vouch, because it's not hard. It's really not hard once you get it right. But if anybody's concerned, let us know now.
I planned on
sure that
sending out an email to you guys too for the folks that do need to go in and change. I just haven't. I have the spreadsheet, so maybe I'll have enough time today, if not early tomorrow, to send you an email if you're one of those places that's going to need to go in and make a change. All right, Henrico.
Janelle, it might be helpful just to send everybody the website.
Come on,
address.
You're asking too much.
No,
now.
do it. Send everybody the website.
I'll think about it.
Thank you, Marion.
I'll think about it, Marion. Henrico, you had a question about the STI forms and the combined STI family planning forms.
I was just wondering if you had an estimated time on when they plan on rolling that out, and if they had a QA and a joint encounter for that.
Good question, Karen. I think that was Karen. Yeah.
So
yeah, it was.
So
hey, Karen.
Yeah. So what we do have, we have a pilot.
Take the mic, Dr. A.
Yes, we have 3 districts that are piloting the forms right now, and then what we intend to do is once we've gotten all the corrections from the districts or the updates, we will have a Polycom, to have a discussion and for everybody to see it, and then come up with, give you 2 weeks to review the forms and any suggestion before we come up with a final rollout date. So that way you can see the forms. We will have a training on the forms so that everybody, will be familiar with the forms. Not having no combined forms.
Combined encounter?
Yeah, maybe.
Lisa is thinking about it.
I'm thinking about it.
Yeah, maybe.
I'm thinking about it.
Yeah.
Yeah, it's likely that it will be a companion document.
Yeah.
On or about the same time as the other forms. Yep.
Yep.
Any other questions?
Yeah, what other questions do you have? Thanks for holding.
This is Debbie from Central Shenandoah.
Hey, Debbie.
Can you hear me?
Yeah.
Oh, hey.
Sorry, you couldn't hear us.
Under the projects related to the 2018 work plan, you have Community Health Worker Association collaboration. Can you elaborate on that, please?
Yeah. Forgive me. I'm going to make everybody sick to go back.
You're going forward.
Okay.
Okay.
Go forward. Go forward?
No, I thought you were going forward.
We're just going to do that.
I was like, you're going. Yeah, that one.
There it goes. Okay. Janelle, take it away.
So that's that's really more at our level. Basically, what we were trying to do is create a reproductive health module, like for the community health workers. And for our information and education committee, because if you recall, we're using the Community Health Workers Association as our information and education committee. So
they review all of your pamphlets that you send in for us to approve. This has to be reviewed by a committee. And the Community Health Workers Association is really generous with their time and agrees to look at that for us to meet the grant requirement.
We pay them.
We also give them gift cards. So nice. So nice.
But no, yes, they let us. We have a standing spot in their meetings. So whenever you guys submit pamphlets or patient education that you want to use in the clinics, we have to take it to this group and they review it, and that's how we get the approval and stay within compliance for Title X.
Thank you.
Mm-hmm.
Sure. What other questions do you have?
This is Debbie. I had the question. You were talking about doing training for nursing, and I can't remember what the other title was. Would that be also for our healthcare technicians?
It's for anyone that does counseling.
Thank you.
Mm-hmm.
This is Cindy. Was there a date referenced for the STI new forms training, the family planning new forms training?
No.
Not yet,
You guys will know. They're still, we piloted it, and the tweaks are being worked out now. So an email will go out when the date's known. And it's a part of your work. It's a part of our work plan. So, we will definitely let you know. Any other questions
do you have? I already got an email asking for some posters.
That's right. This is
Absolutely.
Alicia with a question, and that was my email. Hello.
Yeah, I saw. Hey, Alicia. What's your question?
On the family planning orientation checklist, is it just for the nurses or is it involve the clinicians as well?
It's everyone, but don't worry about it right now because we're going to do a Polycom for it.
Got it. Thanks.
The Family Planning Medical Advisory Committee is looking over I cannot speak, you guys. I'm tired. Is looking over everything right now to just see if it initially makes sense. And once they say it's okay, and once we finish with our manual revisions, we'll set up a Polycom. I don't think initially we weren't expecting to make any huge changes to the manual, but once we got in there, again, we saw some things that needed to change. And so we think it's best to set up a Polycom and go through it with you guys instead of just shooting it out to you with the changes. So we'll make sure we let you know when that's going to happen.
Okay, thanks.
Mm-hmm. Debbie, I got your email. Debbie Bundy Carpenter, I got your email.
Yeah.
Just FYI. So.
And forward that to me because
I gotcha.
I'll let Debbie. So if you did not get posters or rack cards, I'd really like to know that because I can look up where I sent them, and we'll get to the bottom of it.
Hey, this is Amanda in Roanoke.
Yes.
For the 340B recertification, is that per district or does each health department in the district have to do it?
Each health department, each site has to do it.
Each site.
So,
Okay.
Yeah.
All right. Thank you.
Normally, it's the same person for all the sites in a district. Roanoke, Allegheny, I'm not sure. Y'all probably have one for Roanoke and Allegheny sites. But Janelle is going to look and...
It's going to be nurse manager and health director usually.
But I know y'all have had some... We'll double check y'all's. Because you've been without a nurse.
Yeah. If it's not the nurse I think theirs is the business manager. Because the business manager is the point of contact on some of them.
We'll be in touch, Amanda.
Perfect.
Any other... You're welcome. Any other questions?
Yeah, I have just one more question. What is the time period that this work plan is due? What's it covering?
May 3rd. Oh, it's for, I'm sorry, April 1, 2019 to May 31, 2000. I'm sorry, March 31. I'm in May in my mind. March 31, 2020. And it says that on the work plan. When you get into Red Cap, it has that listed for you.
Okay.
So we're back. Yeah, I don't even know if we really discussed that. We're back on the 3-year period. I mentioned it, but we're back to our normal year period. So the year will run from April 1 of the current year until March 31 of the next year for 3 years, and then we'll do a new grant. So even though we're back on the 3-year project period, trainings will be due annually now. So
Janelle and Emily.
Yeah.
This is Rod Sand from Critter. Question on the funding again. Just wanted to make sure when we do a funding request, now we can ask for additional funding that can be spent throughout the project year from April 1 to March 31st, correct?
As long as it's all gone by March 31st. But because this funding is not guaranteed, and we hope it's one time every year, but we're not really sure. This money can't support ongoing costs for existing staff or projects. It just doesn't really make sense for that. But yes, you can spend it over the course of this year as long as it's spent by March 31st. But we're not going to approve requests for ongoing salaries because it's not a sustainable funding stream for that.
And when you get into the application, it'll have, because everything's going to be scored on points. So you'll see the scoring criteria, and ultimately Emily and I will tell you if we think it's something that you can do with your regular allocation, or if we have questions or concerns, we will reach out to you to ask for more information. Because you're going to be expected to submit some kind of report to us too about what you've done, or maybe a presentation for the other districts. We're not sure yet, but.
Are you going to have different project numbers or like task or phase numbers so that we can differentiate?
Not that,
between?
Nope, it won't be that serious.
It'll all be under the Title X project code that your district currently gets.
Just revise your allocation, right?
Yeah, what we would do is revise your MOA to increase the amount according to how much supplemental funding you've received, and then attach your proposal to that. But it would be the same, like, budget numbers and project numbers and cost codes and all that stuff.
Okay.
Otherwise, Title X would be very unhappy with that.
That was
Is this like state funding, or is this coming? This is coming from the feds too. So like
this always comes from Title X. This is the third year now that we've done this.
Yeah. Mm-hmm.
So
this is all. So Janelle and I handle the federal funds. We don't handle the state funds.
Got you. Okay. Thank you.
Sure.
Janelle and Emily, this is Audrey from Peninsula.
Hello.
We were just wondering if there was going to be a way of tracking the gonorrhea and chlamydia testing for our patients if they decline.
If they decline.
Yeah.
Help me understand what you mean.
Like, so if we request that they do it or counsel them on doing it and then they decline the under 25, is there a way of like tracking the percentage or the number of patients that declined, like a counting code or something?
We don't have that set up right now.
Why would you?
I guess the
reason we were asking was because it would skew your numbers. You might be offering it, but they're declining it, so it looks like they're not getting it.
So that should be in your medical record audit. You should see that in the new form.
I agree, but do you see that?
Yeah,
do you see that?
You're going to submit them. You're going to have them on site when we do site visits. Emily and I do look at them. And I'm trying to decide if I'm going to have you guys submit them. Say what?
But your data in Tableau won't show that.
No, but we can run reports out of REDCap. That's why we have you guys put things in REDCap. So I haven't decided yet if I'm going to have you do the audit forms. I've created the audit form, and it's for 12 months. But I'm not sure what I want you to do with it yet. I don't know if I want to just see it on site or if I'm going to have you upload it yet. But it should be documented. It's not that we're trusting you guys to do what you're supposed to do. And if you say you offer it, we're going to take you at your word. If you offer it and it's declined, then it just needs to reflect in the medical record why. Emily, can you go back to that slide?
Yeah, sure. I think the thing is that statewide, our numbers do not suggest that we offer it regularly. You know,
that one.
This one?
Yeah. So see, no test, why not?
So that'll be in the medical
So that's
record.
all we're looking for and that's what we look for now. If when we do our site reviews and I look at your records, I'm just looking to see if the patient didn't get it, why? Patient declined, patient's abstinent, whatever. It just needs to be documented.
We document.
We'll see. We're coming to see you guys this year, so.
And for patients under 25, I know that most of them may not want to get, vaginal exam. A urine test also would suffice. So
yeah, it's urine, self-swab, however you guys want to do it. It's just normalizing it, but we understand that you are going to get people that decline. If someone's married, for example, that's not always, I'm not saying married people don't get STDs, but just saying there'll be a variety of reasons people may decline. And again, it's not your job to make them have testing.
Our goal would never be 100%.
Right. Yeah. It's your job to offer it and make sure they know why it's important to get tested, just like we do with PAPS, just like we do with anything else that we offer. We should be doing the proper teaching to help them make the best decision for them.
What other questions do you have?
So we have site visits. Every year we schedule, I think, 11, Emily, is what we put in our work plan.
It's 11 a year.
So we're about to finish up the last 11, finally. So I know Alexandria has heard from us. We'll be coming to see them. West Piedmont, and then there's a few of you who will be getting emails shortly, and then a few that we'll be following up with. So just be on the lookout. If you haven't seen Emily and I in the last 2 years, you're probably going to see us this year. So that's your heads up. So yeah, we're getting the emails and everything together, trying to figure out our dates, but just know we're coming to see you. I wouldn't be surprised if we have a federal site visit this project period. So just know. We'll let you guys know when we know. But see, is there anything else? Sleepy Simba. So cute. Do you guys have any other questions, concerns, suggestions? You know you're not allowed to email us once we hang up for 24 hours. Speak now, forever hold your peace.
You can email.
They're not allowed to email for 24 hours, Dr. Adekoya. They know that.
You can email me.
Is that a family law?
That's a Janelle law.
That's a Janelle.
They say Title 10 told us.
Title 10 told us that we can do
But
that.
they won't say. Title 10 said.
All right. Well, I'll email the 340B link out to all of you, so be on the lookout. Anyone, if you receive the slides, I'm going to use that same email group, so just be on the lookout. And I guess I can send the link for the supplemental funding in that email, and I'll also send you the hard copy of the work plan, the blank work plan, so that you can see what's on there before you go in there.
Thank y'all for
All right.
everything.
Thank you. Have a great rest of your day. We'll talk to you later.
Talk to you later. Bye. Bye.
Hey Janelle, this is Rich. I was just checking to see if you guys were done. I'm gonna hang the slides up
I
if you
just shot you an email. We're all done. Thank you.
Thank you.